Okay, in the next 15 minutes, I'll cut it short, I talk about whether there's a need to monitor cardiac output, what's the scenario at the present time, what are the modalities available. I'm not going to talk about the principles of those monitors which are available now and they are trying to push it, the industry. A slight literature review which gives us what we can use and what is the carry-home message. I start my talk with a small little conclusion from a paper which was presented in between June 11th and 14th, 2011 in Amsterdam during Euro anesthesia. This doesn't concern parturients, but it gives us an insight to the system. This survey was conducted in USA, and about 1,000 or 1,500 odd questionnaires were sent, and they had about 463 members completing the survey regarding practice of hemodynamic management in patients who undergo high-risk surgery. Mind you, they were not all parturients, it was just high-risk surgery. And 190 people from the European Council and about 273 people from the American Council responded to that. And the results were very interesting because, I'll tell you why. 2/3 of the anesthesiologists who responded did not monitor cardiac output during high-risk procedures. And the reason they gave was that they do not monitor cardiac output because they use dynamic parameters of fluid responsiveness as a surrogate of cardiac output, and because cardiac output devices are too invasive. And the percentage was 58 and 42% respectively. This was despite acknowledging that the importance of oxygen delivery to the tissues and that cardiac output involved in oxygen delivery. 30% of the respondents indicated that cardiac monitoring did not, and mind you, did not provide important information. The authors concluded that it is not enough. They were all talking about monitoring cardiac outputs in various conferences. It is not enough to prove that a treatment or protocol is beneficial to a patient outcome, unless it has to be ensured that it has to be put into practice. Most of the people accepted the fact that cardiac output need to be monitored, but they never did it. And these findings in the month of July and June, if you look up the medical papers, they were thrown over to the normal press. Well, so many percentage of anesthetists really don't take care of the heart, though they accept that the blood pressure and the pulse rate and the saturation and all those monitors are not really enough to take care of your oxygenation. So it came as a big jolt. And then there were guidelines made, and now in various other countries also. So if you go and see the literature, there'll be a lot of information regarding what all anesthesia people are not doing. What I did, well, this was Europe and this was America. I did my own little survey. Talked to people, anesthesiologists of varying age groups. Age groups would mean they would be obviously postgraduates, maybe a couple of years after they finished the post-graduation, and people who were senior enough into practice, both private practice and working in the institutions. And what I got, there were different answers. Well, large number of them said they have never used it, but their outcomes are fine as far as obstetric is concerned. And mind you, I was talking only about cesareans because my talk was about cesareans. About 5% of them. I didn't ask the reason for that. About 84% of them said they are not really needed. They have never used it, they don't find it is needed, and the results are very good. Why do you want to push it? There was a very small group, and I found that they were the younger people who said, not all younger people, but a lot of younger people, they said they could be useful. However, none of them said that it was very necessary for patients or for parturients who were having high risk because of the cardiac problems or whatever problems, hemodynamic abnormalities, would invariably needed something to monitor the cardiac output. So the results were not different. They had done something on surgical patients and they found the similar kind of results. And a large number of people I talked to could have been the ones who have never been exposed, or they couldn't have been working in areas where cardiac output could be monitored. But the fact was this. Now, what are the ideal characteristics of monitoring cardiac output? Well, if you have a monitor, it has to be accurate, it has to be precise, somebody could reproduce the numbers you get, it has to be operator independent, easy to use, continuous use, and all that stuff. And like all the good things, you really don't have such a kind of monitor available. Now this is a list. We normally ask our postgraduates, how do you monitor cardiac output? And well, you may have to make a table and you mention all this. I'm not going to go through the whole list. But these are the modalities which are available to us to monitor cardiac output. And it doesn't really limit itself to be used only in a cardiac theatre. Well, a PAC is used in a cardiac theatre, maybe it's going out of use even in cardiac theatre. What our experience is, and I have about 3 weeks ago there was a paper presented in Delhi, that in the liver transplants, less than 1% of patients who were undergoing liver transplants in Delhi, they normally put a PAC. But they were monitoring the cardiac outputs, and that's where the importance of non-invasive monitors comes in. Just 2 slides about a never-ending debate about an accepted gold standard. This is a strange statement. You have a gold standard, everybody acknowledges it, they did it 15 years ago, they do it really today also, but they still feel there's a debate about it because it's not really, it's really tough to use it, the side effects are very much, the morbidity is too high, you could have patients dying of it or whatever. This is a study which is quoted in number of times. Well, published in New England Journal of Medicine as early as 2003, an RCT performed, which finally concluded over 1,994 patients divided into 2 groups, where in one group the PACs were used, the other group the PACs were not used, and the primary endpoint which they saw was hospital mortality from any cause. And mind you, this was high-grade, high-risk patient, ASA 3 and 4, undergoing surgical patients. They were not obstetric patients. But you could extrapolate the results to the other group of patients also. And what did they conclude? In hospital mortality was 77 versus 78. The PAC group had higher incidence of embolism. 6-month survival was really comparable. 12-month survival was again comparable. And as far as the PAC is concerned, no benefit over standard care in elderly, high-risk surgical patients requiring ICU care. So it's this all started it, but the controversy continues now. The subset of people who require a PAC is becoming smaller and smaller. It's still in use. A large number of people use it. Well, we also use it in the cardiac center. But the usage of in non-cardiac centers is going down and down, and even in the ICUs. What normally people do is they use clinical indexes of adequacy of cardiac output, and they're in front of you. You tend to teach them to every postgraduate or training of yours. Temperature, capillary filling, peripheral pulse, urinary output, and then you go to the labs, ABGs, lactate levels, mixed venous saturation, all that stuff. And now you come to the non-invasive modalities which are available to you. They're in front of you, which are very popular. You have the dilutional techniques, which normally use the Fick principle. You have the LIDCO, the PICO, the flow track, partial carbon dioxide rebreathing, the NICO, and the esophageal Dopplers, and the transesophageal TOE or T, what you want to call it, electrical impedance, and bioreactance. Well, I personally would have an experience of using, I'm not talking about a subgroup of patients, but we in our hospital would have used 3 kinds of these things. One was thoracic impedance, which was the first one to come to us, followed by the esophageal Doppler, and now we have the flow tracks, which we have in multiple theatres. Now we come to the fact that what does the literature tell us about the use of these modalities in obstetrics? I must acknowledge that there are hardly any studies in the literature where the comparison of these modalities with the gold standard, which is PAC, has been carried out in the subset of parturients who are pregnant, obviously, or parturients will be pregnant during surgery or in the ICU. So you have to extrapolate things, but I am limiting myself to studies from the parturients. And I put this table here because this looked very interesting to me. This was a table, some recent publications suggesting new applications and indications of modern non-invasive cardiac measurement. Now, where are the obstetric patients here? No, I don't see any obstetric patients here. If the 4th one from below is in epidural and spinal anesthesia to determine effective but safe dose of lidocaine. They are all different subset of patients, but the obstetric patients are not here. So they have been tried, but this subgroup is missing. So if you go through the literature, this article in Anesthesia in 2008 was very informative, and they stressed one point, that cardiac output is becoming very necessary to be monitored in patients who undergo surgery, high-risk surgery of any kind. At the same time, there was another editorial in Anesthesiology, 2008, which said that PAC has only limited application in the management of complex cardiac defects or multiple organ failure in the parturient. They went a step ahead. It is of limited use, and less invasive cardiac output monitors will have an important role to play in the future. So the time was coming when people were starting to think, well, PAC is not the thing of choice for parturients, and we must look for somewhere else. This is 2009 from Seminars in Cardiothoracic and Vascular Anesthesia, and they also opined. It's an excellent volume of this issue of cardiothoracic and vascular anesthesia, which talks about everything about cardiac output, especially non-invasive cardiac output. And they also find that, well, it is high time that these monitors should come in, and they narrowed down on two modalities. FlowTrack, which is a pulse control module, and LiDICO. I'll come about this. At the same time, this issue came up, this paper was published from New Zealand and Australia, which talks about, it's the Journal of Obs and Gynae from that place. They picked up a different module. It is known as USCOM, ultrasound-based device, a Doppler device which picks up cardiac output, and they didn't do it for surgery. They were doing it in normal pregnancy to see how the pregnancy goes. So the time was coming when the cardiac output was being measured in pregnant patients. There could be normal pregnant patients, but because it was comparatively non-invasive, there were no ethical issues involved if you do a study. So people were trying to get in monitors which would be of use, or their results could be extrapolated to surgical patients. Now this is from Anesthesiology, and this is in 2008 again. And this was the time when from USA and UK, papers started coming in to the use of non-invasive cardiac output monitors in patients even undergoing spinal anesthesia, where they were not used to compare two modalities. They were not initially used, well, we have one modality, let's compare it with a pulmonary artery catheter. This comparison was done in a different subset of patients. So they started using it, and LiDICO, LiDCO, is one of the modalities where lithium is used to calibrate the monitor every time you use it on a patient. Or if there are spikes of blood pressure, or if you're doing it continuously, then you need to you need to calibrate it once in a while. So you use about 0.3 mils of lithium. The issue about lithium is a lot of studies in which I'm going to show you, they have used lithium, and however, you get reports where use of lithium, even if in that quantity, is contraindicated in the first trimester of pregnancy. Now, all the reports which have come in are basically in term pregnancy. I tried to find out whether lithium was really contraindicated, but the results said that it is not. So maybe you are trying to be extra cautious in the first trimester of pregnancy. So now the reports started coming in about lithium-based non-invasive cardiac output monitors, which were used for managing patients who were undergoing cesarean sections. This is another one in 2010. They also gave regional anesthesia for cesarean sections in women with cardiac diseases. They managed these patients with cardiac disease, but they also used lithium-based, LiDCO, which is known as. I personally have no experience in using LiDCO because we don't have it. I really don't know how many centers in India have it, but one of the centers in Delhi doing liver transplant were doing some studies on it. I really don't know where else it has been used. But more and more studies are coming from, as far as parturients are concerned, is from LiDCO. It somehow happens that if you have a modality which is manufactured in UK, you'll have a lot many studies coming from UK regarding that modality. So the next one is again BJ, again 2011, January 2011, and this is the first one which I found, who compared in 18 patients cardiac output measurements between the two modalities, and they found that if they compare it, the results were equally good. They had those statistics involved. The bland, if you know that, how do you do that? The Bland-Altman graph was drawn, and the areas along the curves were very comparable, and you could use this LiDCO for cardiac output, non-invasive cardiac output monitoring for cesarean sections. I have put this here because this is from Japan, and this is a series of triplets which were managed for cesarean sections for when they used a FlowTrack. Now, flow track is one modality which is available in our country in plenty, I think. I'm sure in Hyderabad you would have about 20 of them available in various hospitals. In my hospital itself, I come from Delhi, I come from AIIMS, I think we have about 7 or 10 of these monitors available, other than the cardiac center. So it is easily affordable, it is useful, and people get used to it. All the anesthesia people find it comfortable to work with, though it has its own share of problems. So we have a literature which supports LiDCO and FlowTrack, which is pulse. Both are basically pulse controlled, but for LiDCO you will have to calibrate it. For FlowTrack you don't really have to calibrate it. So these are the ones which are going to last, I think. Now there is another thing which has come up after thoracic impedance. Those of you who know what thoracic impedance is, we used to monitor thoracic impedance and we used to get cardiac output values by putting electrodes on the chest. However, this device had a lot of noise interference. And the results over 3 hours were not very good. They were not consistent. So then came another modality. This is the most recent, bioreactance. The easiest way to divide is, to describe is, well, thoracic impedance versus bioreactance is something like an AM radio and an FM radio. You have an AM radio, you switch it on, you get this noise, you get the sounds, you get the songs, but there is some noise. But with the FM thing, there is no noise. So the bioreactance picks up cardiac output. They all work on the same principle of resistance in the vessels when the blood flows, when the size of the chamber changes. But bioreactance will pick up all this from frequency. So the results are good. There is no noise, and there are 2 reports. First was a case report by the same author, and if all of you guys who have come to Chennai, Carvalho was there himself. He has a report about 4 months before this article, a single case report, and then this study was published in the Brasilia Journal of Anesthesia. They have found it very useful. However, I'm sure this modality also would have been provided to them free of cost by the company people. But the fact is, it comes from a very reputed group of anesthesiologists, and this is maybe also a modality for the future. This is an editorial which is written by Chikani and Mopat in BJ, which says, what evidence do we need more about minimally invasive cardiac output? It has become a norm in UK that if somebody is undergoing GE surgery, one needs to use a non-invasive cardiac output monitor, and the most commonly which is used is ultrasound, a Doppler. The probe is available both as a multi-user probe or a disposable probe. So I think they talk about having this modality for GE surgery patients, and which could be extrapolated to parturients. This is the last of the literature slides, and I've put it here, though it came out in 2008, because this gentleman questioned the very idea of a non-invasive cardiac output. They said, fine, it's there, you can monitor it, you don't have to go through the neckline or the femoral, but this modality was never made to check the frequent changes which take place in cardiac output in parturients or in parturients who are undergoing a cesarean section, because this is not comfortable. You'll have to have better monitors, better gadgets to do it. Right, I have a minute, you are finishing. So when we have high-risk patients who are undergoing cesareans, what does cardiac output help us with? It can help us in monitoring them, in individualizing the fluid responsiveness, in decreasing the dose of vasopressors, which had been shown it decreases the dose of vasopressors. So now I conclude on this. Is cardiac output monitoring indicated in these patients? Yes, it is. Are non-invasive techniques reliable? Well, it's difficult to answer at this point of time in parturients. Which technique is the best? Which modality is the best? Well, there is no literature proof for one to score over the another at the present time in the peripartum period. It's very likely that LiDCO, the flow track, and the bioreactance most probably will be the ones which will be used in the near future. And I would suggest that it's best to use any of these. The first 2 are available in the country, like I said. The ones which are available in your hospital, you could use that to monitor the cardiac output. Thank you.